everyone. This is our second session in MSK Viva Hot Seats. Today we have very long list, about more than 30 cases, uh, many varieties. I think it is one of the strongest session that we will make. Hopefully, all of us have many benefits. Let's start. This is 35 years old male patient after trauma.
So should I start?
Yes.
Okay, I am provided with radiograph frontal and lateral projection of skeletally mature patient. First, I'm looking at the frontal projection, and I could appreciate the scaphoid appears fractured. The lunate appears triangular in shape. The rest of the visualized carpal bones, metacarpal bones, and distal radial ulnar joint are normal. So can I have the look at the lateral view? Okay, on the lateral projection, there is a dorsal dislocation of the capitate. The lunate appears to lie within the radial groove. So I'm thinking of transsphenoid perilunate dislocation. And I would like transscaphoid fracture with perilunate dislocation. And I would like to I would send the patient for the orthopedic review.
Could you think why this is not a scaphoid? Why this is not a lunate dislocation?
Sir, because lunate appears to lie within the radial groove.
Okay. Could you tell me the name of this sign?
This is some pi something. I can't remember exactly. Pie in the sky sign.
Excellent.
Triangular.
Yes, number 2. Years old male patient complaining of neck pain, dysphagia, ornithophagia, and consequent progressive body weight loss.
Okay, I'm provided with scanogram,
Yes.
lateral projection, and I could appreciate significant pre-vertebral soft tissue swelling.
Yes.
The vertebral bodies appear slightly straightened. I would like to further review the CT scan images. On CT scan images, I could appreciate large fluid collection in the pre-vertebral region. So can you scroll down, please? Extending in the superior mediastinum, there is a left-sided pleural effusion with underlying lung compressive atelectatic changes. The rest of the heart and major mediastinal vessels are normally contrast-opacified. I think there was some soft tissue opacity in the lung. Can you please scroll downward?
Which sequence do you want?
No, this is fine. I think it's consolidation.
Fine.
It's consolidation.
Yes. What's your diagnosis?
Sir, I'm thinking of retropharyngeal abscess, and I would like to see the source if there is any infection in the tooth, or can you show me the dental bone window, mandible in the bone window? No, I think it's fine. Might be patient is some having dental fillings and artifact due to that. The spine also seems fine. I could not appreciate any changes of spondylodiscitis on given CT scan images. So my first is I'm thinking of a retropharyngeal abscess, and I would inform the primary physician regarding these findings.
What's your next step?
I'll inform the primary and send the patient for ENT referral might be.
Okay. Anything else?
Um, Nothing.
It's your
Sorry.
differential. It's your differential.
Fluid collection in the posterior.
Okay. Don't worry.
Okay.
35-year-old female patient after
Okay.
twisting knee, her knee immediately swollen.
Okay, I am provided with the mRNA images, and I could appreciate double PCL sign.
Excellent.
Can you show me the coronal? I would like to see the medial meniscus on the coronal view.
Okay.
There is contusion, bony contusion
Okay.
noted in medial tibial plateau.
Okay.
There is bucket handle tear involving the medial meniscus.
Okay.
And there is mild joint diffusion with the fluid in suprapatellar joint space. The medial collateral, lateral collateral appear fine. I want to see the PCL is also fine. Can you show me the ACL? I could not appreciate the ACL.
So, your diagnosis?
Medial meniscus injury, tear of the medial meniscus and ACL. Unhappy triad maybe. Unhappy triad.
How could you diagnose unhappy triad?
There is injury to medial meniscus, ACL, and
what else?
there's just the bony contusion.
Okay. What is the name of this sign?
Double PCL sign.
Excellent. Where? Could you tell me where is the fragment displaced? The displaced fragment? Where it is displaced?
It's in the intercondylar notch.
Excellent. There are another sign here other than ACL. What is this sign? This sign name also?
No, I couldn't remember. Sorry.
No problem, but you did well in this case. Could you know the mechanism of injury in ACL and the bucket handle tear of medial meniscus?
Not really. Maybe hyperextension injury.
Okay. This is just a question for more marks. Don't worry, you did well in this case. 50 years old female patient presented with left hip pain, worsened with activities.
Okay.
This case, an observation case.
Okay.
This case has not too much pathology. Okay.
There's just
you can start, please.
I could appreciate mild fluid close to the left ischial tuberosity with some maybe avulsion of the ischial tuberosity. I would like to see the radiograph if available.
No history of trauma. Radiograph is normal.
Just there is fluid around the ischial tuberosity and there is
Excellent. What is your differential diagnosis for this region? You pick up it well, but give me other differential diagnosis.
Maybe it's a trochanteric bursitis.
No. What else?
What's
what is the name of this space? Okay, don't worry.
Sorry.
No. See, yeah, this is cases. I know many tricky cases. Last case was one of the tricky cases. 14 years
Okay.
old male patient. The patient has low back pain. This patient is a sportive
Oh,
patient. Yeah, you can start, please.
sorry, I couldn't see the screen. Please wait for a minute. Yeah. No, 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 I can look at the screen. So I'm
You can see?
provided with MRI. Yes, yes, I can now. I am provided with MR lumbar spine of a 14-year-old patient, and I could appreciate some bright signal within the pedicle
Which?
and lamina of uh, some hyper-intense signal within the pedicle and the
Mm.
lamina of L3 vertebra. Uh, I want to confirm if it's on the right, on the left. Rest of the vertebral body heights and intervertebral disc signal is normal.
What's your
I
differential?
could just appreciate an edema signal. Can you please scroll it?
See?
I'm thinking of some on T1 it's low, and
Yes?
on T2 it's bright. Maybe is there any history of trauma or something?
No trauma, but this is athletic adolescent.
Uh, then there may be some lesion like osteoid, osteoma, or osteoblastoma. I would like to know if patient has any history of night pain.
What else? No night pain. This is just after training. He go to gym regularly.
Uh,
What else? You are in the
this
correct
might be
pathway.
due to
What else? Yeah, you are correct. Osteoma, osteoblastoma. And what is the last differential diagnosis for edema in the pars in athletic adolescent?
maybe some stress fracture.
Yes, excellent. Excellent, doctor. Our 15 minutes is up.
Thank you.
Okay. Last case.
Okay.
Last case. Our
Okay.
15 minutes finished or not? I think still we have 1.5 minutes.
No, we have 2
60,
minutes.
yeah, 60 years old male patient have a spiking temperature and the lower abdominal pain. 60, yeah, you can start.
Okay, I'm provided with CT scan images, and I could appreciate low signal within the adductor on the right. Uh, uh, in addition to that, the aorta and the psoas appear normal. I uh, um, Can you please scroll downward? I could appreciate left-sided fat-containing guanyal hernia. The right adductor, bilateral adductor muscles are swollen and have
Excellent.
edema signal within them.
Excellent.
I'm thinking of some myositis
What
or
will you do next?
any infection.
Excellent. Excellent. What will you do next?
I would like to do like MR of the pelvis.
This is MRI of the same patient.
Okay.
You can start.
Yeah, there are intramuscular abscesses noted within bilateral adductors muscles. Uh, these there are fluid collections that are intercommunicating and peripherally enhancing. I could not appreciate any signal within the bone.
Yes.
Yeah,
What's your
and
diagnosis?
uh, the joint also seems fine. Um,
Excellent.
um, I'm thinking of
Joint
some
what?
intramuscular abscess.
No. Tell
Couldn't
me
think of the
about
cause.
the joint. The joint, normal or abnormal?
They- I think they are normal. I couldn't see any joint diffusion or anything like that. The bones are also fine.
So, what's
Can you
your
show them
differential?
to me again?
What's your differential?
I'm thinking of intramuscular. No, the pubic symphysis. Can you show me the pubic symphysis again, please?
Yes. This is
I could I
symphysis.
could appreciate edema with bilateral pubic bones and the pubic
Yes.
symphysis joint. So I'm So I'm thinking of septic arthritis and osteomyelitis of the pubic symphysis
Excellent. What will you do
with
next?
intramuscular abscesses. Sorry.
What will you do next?
I'll inform the primary. I'll correlate with the labs and
Yes.
ask if patient has any prior history of. Does the patient have increased WBC and RBC or ESR/CRP, or are they normal?
Yes. 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 Thank you, Doctor. Thank you. You did very
Thanks.
well, especially in the last case. You pick it up, especially in the CT, despite it is abdominal CT. This film, my colleagues, is this CT. 1 second, it will download. This film, this is a conventional CT of the abdominal pelvis, and the patient has pelvic or abdominal pain. But the pathology in the edge of the film. Take care, my colleague, of edge film. Is very critical because see here, there are a big abnormality here. Thankfully, Dr. Mariam picked it up well and go to the next step in this in here correct pathway, and this is post-contrast T1 fat-SAT MRI of the pelvis showing septic arthritis of the symphysis pubis associated with bilateral peripheral enhanced fluid collection in both sides of adductors in both sides. Your diagnosis correctly, she made it as septic arthritis complicated by bilateral adductor abscess. Thank you, doctor. But see, Dr. Mariam, I have some notes. Take it for you. You delay. You are waiting me to ask what is your next step in all cases. Second, in all cases, you didn't tell me about the technique. When I bought one film or one examination, especially MRI, you should tell me this is axial, this is coronal, and which signal, T1, T2, like this. Okay. Second point, management. Don't wait the examiner, my colleagues, to ask you what's your management. As I told you before, tell your finding and then differential and management immediately. 2 minutes, the examiner will be happy. You, Dr. Mariam, I gave you 7/8 in last case because you did it well. In this case, you struggle a lot, but you picked up it. 14 years old and athletic, you should guess your diagnosis. Okay, you did well when you pick up this edema bilateral, but you didn't say this is bilateral, and you bought a differential diagnosis, osteoid osteoma. But osteoid osteoma can't be bilateral like this. And if you see here, the bars is break. So this is bilateral stress fracture or bars break. What is the treatment? This is conservative treatment. I give you also 7/8 in this case. This case, you struggle and you just told me there are edema here. See, my colleagues, compare this. This is the SQ femoral impingement syndrome. SQ femoral impingement. What happened here? The quadratus femoris muscle belly is severely compressed between the lesser trochanter and the ischium here. So it is markedly edematous. If you wanted to diagnose, you should measure the distance here. A cutoff point should be less than 15 millimeter. Second point, compare here. The ischiofemoral space here is very good, very wide. By the way, this is cause too much pain for the patient. And why I bring this case? Because even in the practical, many of us miss this diagnosis. Many of us, all of us looking at the hips, looking at the sacrum, looking at the sacroiliac joint, and we forget to tell about the ischiofemoral space. I give you 6/8, but you pick up at least some edema. This is not unhappy triad. Unhappy triad, okay, this is double BCL, And Radiopedia mentions there are double delta sign. This is what I asked about you. Lateral meniscus is good. ACL is not seen associated with posterior femoral translation. This is very important to be mentioned. Okay. If you want to diagnose unhappy triad, you should look at the medial collateral ligament, which is completely normal. So this is not unhappy triad. In sagittal, in coronal, this is the PCL. Okay. This is the PCL. How we could know it? Look at the medial femoral condyle, inner aspect or outer aspect. Okay. A PCL connected to ACL connected with the inner aspect of the lateral femoral condyle. We should see something from here. Nothing. No any ligament from the inner aspect of the lateral femoral condyle. Okay. This is the displaced fragment to the intercondylar notch. We should also look at the axial to rule out any retinacular injury, any cartilaginous. I think here there are some cartilaginous edema, but I think no any ulceration. So this is a case of ACL and medial meniscus bucket handle tear. This case, Doctora Mariam, you didn't give the proper differential diagnosis. And when I ask you what sequence or what image you wanted to see, you told me this is enough. When you see, I think I was showing you this. Okay. Okay, this is a perivertebral multiloculated peripherally enhanced collection, which means abscess. Okay, prevertebral or retropharyngeal, no problem. But you came here and you told me there are upper lung consolidation. Very good. Ask me for this lung window. If you see lung window, you will get the answer. Consolidation. And what else? Tree in bud. Tree in bud. This is very important. And this is will change the management and the scenario of the case. Take care, my colleagues, to change the window, especially in long reporting. Many cases, the key in the bone window or the key on the abdominal window, if you have a chest, or if you have a neck like this, you should change to lung window. This is a tuberculous prevertebral abscess associated with osteomyelitis or erosion of the vertebrae. So the scenario is completely changed. First question I ask you, what is your next step? Any prevertebral abscess, my colleague, we should cure, save our upper respiratory tract. This is life-saving. This is very critical, and this is very important question. Take care, my colleagues. Second, I should isolate the patient. Why? Because this is active pulmonary TB. How could we know? From the tree in bud. Tree in bud or cavitating pulmonary lesion, both of them indicate this is an active pulmonary TB and the patient is highly infectious. After that, I should tell the preventive, after I refer to whatever the spine surgery, NT for evacuation, we should, under anti-tuberculous treatment, we should inform the preventive medicine authority. Why? Because TB is highly infectious. And the contact should be screening for TB also. This is the template of TB patient. My colleagues, you must meet one TB case in your exam. You must. Why? Because it is very common and it is a radiology task. First case, which was a startup case, you pick it up well. You got 7.5. This is a piece of P sign, a fracture of scaphoid, and this is a transscaphoid perileonate fracture dislocation. Why is this not a scaphoid? Why this is not a leonate dislocation? Because the leonate is in the alignment of the radius. Which more severe, perilionate or leonate dislocation? Leonate dislocation, because it is completely destroy the stability of the wrist. Thank you so much. You did very well. Next patient, next candidate, sorry, Dr. Soha. Next candidate. Hello.
Hello, sir. Hello.
Next candidate.
Hello, sir. Can you hear me?
Yes. Let's start.
Yes, sir.
55-year-old female patient with lumbar pain. She has a history of breast neoplasm. Go on.
Okay, sir. Provided of the sagittal images of lumbar CT of lumbar spine
Yes.
with history of previous breast malignancy. There are some lytic areas which are seen in the L5 vertebral body.
Yes. What's your differential?
I'm seeing. So with history of breast malignancy, the first thing would be considering metastasis.
Okay.
And
So
also I would like to see this in the bone window image.
this is a bone window. Excellent, doctor.
Okay. So in this bone window, I can see some thickened trabeculations and areas of mixed sclerosis and lytic foci.
Yes. So give me differential.
So I would also consider the differentials of vertebral body hemangioma.
Yes. And what else?
So because of the history of breast malignancy, metastasis has to be ruled out. So for that, to get a MRI of the lumbar spine.
MRI of lumbar is one. This is MRI.
So in this fluid sensitive sequence of lumbar spine sagittal images, there is subtle high
Excellent.
signal involving the L5 vertebral body.
So what's your
And
differential?
okay, in this T1 weighted image,
Hmm.
the marrow signal is maintained. So I'm thinking first in view of hemangioma rather than the secondaries, because the signal is still maintained.
Okay.
The high it is mixed signal, and even the low signal part is not lower than the corresponding paraspinal muscle signal.
Yes.
I am also seeing for any posterior element involvement.
What will you do next?
So I'll convey these findings and discuss under the MDT.
Okay.
Because of
20 years
posterior
old. 20 years old female patient has a palpable swelling at the arm.
Okay, sir. So provided is the frontal radiograph of the left arm with palpable swelling in a young patient. So first thing I'm noticing is there is a periosteal reaction in the
Yes.
proximal shaft of the humerus, and there is some areas of sclerosis within the medullary cavity region at the same region. And in this in this orthogonal image, I can see this outward projection of this lateral cortex of the humerus, and it has some
What's your
continuity
diagnosis?
with.
What's your differential?
So first I'm thinking of, because of the medullary cavity and
Again,
the
please,
outward
because
projection.
your voice interrupted. Again, what's your differential?
So first I'm thinking of osteochondroma, sir.
What will you do next? Hello?
Hello.
What will you do next?
Hello, sir. Can you hear me, sir?
Yes, yes. What is your next step?
Sir, I would convey, yes, sir. Sir, first I would convey these findings to the orthopedician and ask for any previous imaging if it is a known case, and if there is a recent onset of pain or a recent onset swelling, I would
The patient have pain.
get an
Patient have pain in
yes, sir.
his arm. What will you do next?
To do MRI and see for any transformation or any secondary mass effect changes, sir.
Here is MRI. Okay. Is the MRI?
Hello, sir.
Yes, this is the MRI. Could you tell me
Yes,
your
sir.
diagnosis, please?
Yes, sir. These are axial fluid sensitive images of the same patient. I am able to make out the bony
Fluid
outward projection
sensitive
of
or fluid sensitive fat set?
fluid sensitive fat site images, sir.
Yes. Mm.
And I can make out the bony outward projection, and I can see the marrow signal continuing with that lesion, and
What's your
it is causing.
diagnosis?
Sir, I'm thinking of osteochondroma, sir, with some surrounding mass effect.
Could you measure anything here? Do you want to measure anything?
Sir, I would like to measure the cartilage thickness, sir, to see for any malignant transformation.
What do you think is the cartilage here favor the malignant transformation or not?
So could you show T2 images?
T2 images. This is T2 images. What's your answer, please?
Sir, sir, it is not thickened, sir. The cartilage cap is not so thickened, sir.
Okay, next case.
Yes, sir.
65 female patient with vague pelvic pain.
Okay, sir. Provided are the images of an elderly female with vague pain of pelvis with both hips. So
Yes.
first, so first thing I'm seeing is I'm just taking a look before I comment.
Okay.
Okay. Okay. So there are some areas of hazy sclerosis in the sacroiliac left sacroiliac joint,
Excellent. What's your definition?
and some even in the ischial tuberosities.
Okay.
And there is some calcification along the right greater trochanteric
Don't worry
incision.
about it. Concentrate at the sacrum and give me some related differential diagnosis, please.
Yes, sir. So hazy areas of sclerosis involving bilateral sacroiliac joints.
Mm.
So in an elderly female, I'm thinking of a bilateral sacroiliitis. Differentials include hyperparathyroidism and
Mm.
then
What else?
gout,
What
seronegative
else?
arthropathies,
What
seronegative
else?
arthropathy,
What
um,
else?
then psoriatic arthropathy, Reiter's
What
arthritis.
else? What else? This is a sclerosis in the sacrum. The
Sclerosis
sacroiliac joint is looks normal according to the age. What else?
okay. The other one is any chondrogenic lesion of the sacrum, such as chondrosarcoma.
What do you want to do next?
So I would convey these findings to the orthopedician and get an MRI of the sacrum.
This is a CT.
Okay, sir. So axial, provided of the axial CT images in bone window of the pelvis.
Yes. What's your
Okay, sir.
diagnosis?
There is
Hmm.
one second. I couldn't see the images, sir. It's just skipped.
You can see now?
It's not moving, sir. Image.
Would you see it?
No, sir. It's just skipping. Only one image I can see.
You can see?
I'm not able to. Sagittal, I think. Not it.
Is the image visible for you now?
It is stuck in one single coronal image. Now
What do you
one
think
axial
about
image got loaded, sir.
yes,
And now
sclerosis of the sacrum in old age? What's your differential diagnosis? Is this aggressive or non-aggressive? Not aggressive.
there is there is sir, it is non-aggressive areas of sclerosis and lysis. So I'm thinking another possibility is Paget's disease in a mixed lytic and sclerotic phase. There is no significant destruction of the sacrum or soft tissue component. There are several areas of lysis and coarse and trabeculations involving the sacrum.
But will
The
you do
joint
next?
is spared.